Hello everyone, this is Michael Abraham. I'm presenting today the case for Mr. Artie. Mr. Artie is a 56 years old male, complains of depression and has a desire to take control of his life again. Mr. Artie had an COPD exacerbation in March of last year, which was treated as an outpatient with no need for hospitalization. 3 years ago, Mr. Artie experienced asthma. He was treated with PCI, including a drug-eluting stent, aspirin, clopidogrel, metoprolol, and atorvastatin. He didn't have any sign of symptoms of heart failure. His ejection fraction remained normal at 57%. Mr. Artie is presenting today with signs of severe depression. He has suffered from depression since his heart attack 3 years ago, and he has depressed mood for the past 6 months. He does not have any interest in his hobbies and has a constant feeling of guilt, fatigue, and worthlessness. He feels less inclined to spend time with friends and had troubles recently with his ability to concentrate at work. Colder weather, holidays, and spending his birthday alone contribute to his overall feeling and make his depression worse. Mr. Artie does not exhibit suicidal ideation or any symptoms of bipolar disease, mania, anxiety, or insomnia. Mr. Artie attempted treatment for depression with citalopram 3 years ago. It worked well for improving symptoms, but he complained about some side effects like erectile dysfunction and diarrhea. Today, he needs to get a treatment for his depression, but doesn't have this side effect. He is willing to quit smoking. He will like to exercise again and lose some weight if he can breathe a little better. He does not exhibit any sign of bronchitis with his COPD, but does have symptoms of shortness of breath with walking and during exercise, but not at rest, which has limited his ability for exercise. Mr. Artie is compliant with all his medication. Mr. Artie AAT testing was unrevealing for alpha-1 antitrypsin deficiency. He vaccinated at last visit for Nomivax 23 and influenza vaccine. He has abnormal mood, appetite, and he gained weight 15 pounds in the past 6 months. His blood pressure a little bit high, 138/86. His liver function a little bit high. His ALT is 42, AST 47. His FEV1 is 60. His QTC is 457 millisecond. Eosinophil count is 50. CAT score is 21, and HAM-D score is 16. So if we move forward for his past medical history, so he has a STEMI, high cholesterol, depression, all diagnosed on December 18, COPD in March 2020, and has hypertension for sure. His social history, he's married for 24 years. His wife passed away last year. He's a current smoker. He smoked one pack per day. Alcohol use, he occasionally drink alcohol more in the past weeks because of the holiday season. No illicit drugs, no exercise, diet. He increased calorie intake in the past 3 months, which is reflect on his weight. He gained 15 pounds in the last 6 months. Family history, his father had a depression and chronic CV disease, and he deceased. If we move on for his medication, he on metoprolol succinate 50 milligram tablets, fluticasone 100 mcg inhaler twice a day, albuterol inhaler 2 puffs every 4 hours as needed for shortness of breath, atorvastatin 80 milligram daily. His OTC medication is aspirin 325 daily, vaccination, Nomivax 23, and influenza vaccine. His allergies to adhesive. So his problem list, it's gonna be depression, it's acute and high priority. COPD is chronic with high priority as well. Smoking, it's a chronic and medium. hypertension, chronic low, cholesterol, chronic low, both STEMI, chronic low. So the assessment for his depression is gonna be according to DSM-5 criteria. Mr. RT meets the criteria. He has depression mode, dimension, interest, more than 5% weight gain, fatigue, feeling worthlessness, guilt, dimension, concentration, symptoms present more than 2 weeks period, in addition to change from previous functioning. According to HAM-D score, which is 16, Mr. RT suffered from uncontrolled moderate depression. Risk factor, he has a family factor because of his father. Major life change, his wife died. Serious medical illness, STEMI and COPD. Poor social support, he was lonely, was his birthday. The medication as well as amitriptyl has 2% side effect for depression. The goal of therapy is gonna be within 1 week improvement in energy, appetite, 2 to 4 weeks improvement in sadness, attention, anhedonia, 8 weeks or longer for antidepressant effect. So as assessment of current treatment, citalopram is not appropriate for a couple of reasons. First, the patient doesn't like it because of its side effect of erectile dysfunction and diarrhea. Second is a QT elevation. His current QT is 457 millisecond. So if I go for his plan for treatment for depression, so I choose to start with Wellbutrin XL 150 milligram BOQ AM and titrate up so he can get it 150 milligram once daily in the morning for 3 days and then or 7 days, and we can increase to 300 once a daily. The maximum dose is 450 per day given as a single dose. My rationale for my choice is the SSRI not appropriate because of the sexual dysfunction, erectile dysfunction, and the QT interval, and the patient doesn't like it. The SNRI is gonna be the same thing in addition to elevation to his blood pressure. The tricyclic antidepressant is gonna be the same thing for the sexual dysfunction and the tachycardia, other side effect and weight gain, and it's gonna be deadly in case of overdose. Mirtazapine is not appropriate because of side effects and as well the weight gain. Nivazoline because of hepatotoxicity, trazodone, the side effect and sedation, and MAO inhibitor, drug-drug interaction, food restriction, all of those are non-appropriate. If we go to Wellbutrin XL 150 would be appropriate because it's the most activating antidepressant and it will help the patient with his fatigue. It will help patient to stop smoking as well, which we're gonna put this for his plan to help him with his COPD. And it doesn't have the side effect he doesn't like, which is sexual dysfunction and diarrhea. And we're gonna advise the patient to take Wellbutrin in the morning to avoid the insomnia or difficult sleeping. My non-pharmacological is gonna be psychotherapy, CBT, interpersonal psychotherapy, problem solving therapy, psychodynamic therapy, in addition to physical activity as well and exercise. Monitoring is gonna be the assessment of the response of therapy. So it should be within 1 week improvement in energy and appetite, 2 to 4 weeks improvement in sadness, attention, anhedonia, 8 weeks or longer for antidepressant effect. We're gonna modify the treatment in case of partial, which is 25 to 50% of the response, or in case of no response after 4 to 6 weeks of the therapy. My patient education is gonna be about taking Wellbutrin in the morning to avoid trouble sleeping. Should be taking at the same time every day. Avoid alcohol with it. In case of missed dose, skip a missed dose and take the next dose at a regular time. report symptoms of seizure, new worsening depression, suicidal ideation, unusual behavioral change, psychosis, mania, or hypomania. Don't use with other drug for smoke cessation. If we move on to his COPD, it's gonna be the assessment for disease according to GOLD guidelines 2021. RT has an uncontrolled COPD GOLD 2 group B. So it's GOLD 2 group B because his FEV 160, which is between 50 and 80. So it's GOLD 2 and CAT score 21, which is over 10 with one exacerbation not leading to hospital as admission. So it's gonna be GOLD 2 group B. The risk factor for sure is gonna be smoking. The goal of therapy: reduce symptoms, improve exercise tolerance, improve quality of life, reduce risk, prevent progression, prevent and treat exacerbation, and reduce mortality. So the assessment of current medication, as a result of previous disease assessment, so Mr. RT should be treated with LABA or LAMA or combination. So the patient current COPD medication is not appropriate because the fluticasone 100 mcg inhalation is not appropriate because there is no need for a steroid, and in addition, the steroid have a problem for risk for pneumonia and other stuff. So patient was compliant with the medication, and the albuterol 2 puffs every 4 hours as needed for shortness of breath. It's okay as a rescue inhaler. So my plan for Mr. CT for his COPD is gonna be according to the 2021 Global Initiative for Chronic Obstructive Lung Disease. The recommendation medication, as I mentioned before, it's gonna be LABA or LAMA or combination LABA and LAMA. In case of Mr. RT, because of his severe shortness, like severe breathlessness, I'm gonna recommend starting LAMA and LABA. So I'm gonna go for steltorespimate, which tiotropium and olidotrol, each 2.5 mcg. It's gonna be 2 puffs once daily, and continue albuterol as a rescue inhaler. My rationale is there is no clear evidence to choose one of LAMAs over the other because all of them with the same efficacy. So I'm gonna pick the one for which is tiotropium. Second, combination of LABA and LAMA is improve FEV1 and symptoms, which has evidence B, and reduce exacerbation evidence B. And when the case of the CAT score is over 20, it's better to get them in combination over to get it monotherapy for LAMA. So because of Mr. RT has a CAT score over 21, so I'm gonna recommend that for him. In addition, there is no elevated eosinophil, it's just 50, so no need for corticosteroid. Patient doesn't have history of asthma, no need for inhaled corticosteroid, and other treatment like azithromycin, roflumilast is not appropriate because of the QTc and side effects, and it's not according to guideline. So if I move into the non-pharmacology, it's gonna be smoke cessation, pulmonary rehabilitation, oxygen. Vaccination, I recommend COVID vaccination and Prevnar 13 when he turns 65. Patient education, proper inhaled techniques, smoke cessation, proper inhaler cleaning. The monitoring, it's gonna be symptoms relief, improvement, exercise tolerance, improve quality of life, FEV1, FVC ratio, CAT score, MRC grade, and exacerbation. And I put a couple of references here for the trials I pulled and the guidelines. Thank you and have a good day.